So that'll make sure that the audience hears you as well as folks that might view this in the future. And everyone that has a question will be invited to ask just a single question first, and then we'll allow everybody who has a question to go before inviting folks that have already asked the question to ask another. So pick your favorite first, okay? Okay, so we have a very distinguished panel here, and I would direct you to open up your program and read a little bit more detailed brief bios about our presenters. So I'm gonna just go ahead and introduce them in the order that they'll be speaking today so that you know who we've got. The first I'd like to introduce is Karen Schultz, who is here to my right. She's the Vice President of Behavioral Health among her many positions with the Queens Medical Center, and she is, has a background in psychiatric nursing. After her presentation, we're going to hear from Dr. Michael Christopher, who is both, has doctoral degrees in sociology as well as clinical psychology, which means he sees the world macro and micro at the same time. And he works full-time as a police psychologist in the Human Services Unit of the Honolulu Police Department. So, yeah. But I don't think he knows any of the cast from Criminal Minds, but you can ask him yourself later. And then lastly, I'd like to introduce Wendy Morriarty, who is the state president of the OhanaHealth plan, who also has a background in psychiatric nursing as well. So that's our distinguished panel for today. So we're going to boogie, if that's okay with you. Please.
Well, good afternoon. So the title of my presentation today is, if you want to save healthcare dollars, you need to treat behavioral disorders early. And so we're going to talk a little bit about the prevalence of behavioral health disorders, understand Hawaii's impact that may increase the costs, and then also describe some models of integrating behavioral health in primary care. So look at the prevalence. So basically, everyone in this room has a 50% chance of having some mental illness in their lifetime. About 25% of the population has a mental illness at any given time. So if you compare that to diabetes, hypertension, arthritis, or other chronic diseases, actually mental illness is far more greater. But many times when we think about mental illness, people kind of go to the psychotic disorders, the schizophrenias and other things. But really, the most common is depression and anxiety. And actually, anxiety disorders are probably one of the most common disorders. So if you look at the top hospital admissions, and this is really for preventable admissions, mental health is the top. Why is that? People don't get care early enough many times, and so their disease progresses. Just as if a diabetic was not diagnosed and went on for years, they'd have many more complications of their diabetes. Same thing with mental illness. The costs that have increased in Hawaii relate back to when the state wasn't doing so well, and there were many cuts, and there was $25 million cut from the Adult Mental Health Division. And you can see the impact of that. The ER visits rose 20%. The cost of inpatient mental illness admissions rose to $98 million, $98.3 million, a 30% jump in those last few years from when the cuts were made to the state. It's also estimated that the meth addiction in Hawaii costs $500 million a year. And that includes incarceration, the criminal aspects, and all of those things together. So if we want to save money, we should treat these early. So in the private sector, in Hawaii, we have private sector and public sector, and some that are a bit mixed. But really, we have acute inpatient hospitalization stays, which are about 3 to 5 days, both for children, adolescents, and adults. We have residential care for child and adolescent, and there's a few providers of that in the state. And we also have it for substance abuse disorders. There's partial hospitalization, there's intense outpatient and day treatment, and of course we have a variety of clinics, psychiatrists or other therapist visits in the community. But what's missing? If you look at that, residential for adults is missing. And many times people need that stabilization of the acute inpatient stay, but they need a longer stay for treatment. Now, we do have Hawaii State Hospital, but because of how Hawaii has progressed in the forensic system and things, it's really hard to get a civil commitment or a person just needing longer care that isn't forensically encumbered into the state hospital. So that care is really needed in the community. And also a variety of community resources. We'll hear later in this presentation about some resources that are being developed to enhance more community resources. But why are costs high? So you look at stigma. And if I asked in the community or in the audience today, how many of you have arthritis? Many of you may raise your hands. But if I asked, how many of you have an anxiety disorder? You may not be so free to raise your hand. Or how many of you have alcoholism? Again, many of you may not raise your hand, and that's because of stigma. People may think that you're lesser than, that you have moral weaknesses, all these types of things, when these are chronic illnesses, and they need to not have that stigma. Access to care. Only 1/3 of the 180 psychiatrists in Hawaii accept Medicaid. Why is that? We heard a little bit this morning, there's a lot of red tape. There's more pre-auths, there's more paperwork. And also, the payment is low. Also, these patients tend to be more complex, so the time involved is greater. There's lack of integration with primary care, and I'll get to that a little later. And also, disease is advanced by the time people actually get to the care. So what are some of the solutions? Really integrating the care into primary care. Mental illness, diabetes, other chronic diseases should be all viewed as the same. If you treat a mental illness, your compliance with diabetes, asthma, other chronic diseases will probably be much better because people are attending to all their illnesses. Medicaid and Quest, we heard this morning they're increasing payment to Medicare levels for PCPs. I would hope we could get better payments for psychiatrists in the community, for hospitals. As a side note, Queens Medical Center, we see quite a few patients with behavioral health disorders. 45% of those are Medicaid patients. Per admission, we lose about $6,000 per admission. If you look at Medicare, which is 21% of our population, we break even. So we've reduced our costs enough to break even with Medicare, which is pretty significant, but we lose a great deal with Medicaid. We need to also increase the availability of outpatient services and case management. Many hospitalizations do not need to occur. They need to be managed in the community. And again, we need that adult residential care. So it is proven that integrating the care saves money. So there was a meta-analysis done on 57 studies, and they showed that overall it was about a 27% reduction when you integrated primary care and care for mental illnesses. 40% savings with the Medicaid population. If you looked at the older generation, they had a 70% reduction for inpatient costs. And overall, it's about a 20 to 30% savings when care is integrated. We've long heard about the cost effectiveness of substance abuse treatment. It's been in the literature for decades, and it does save money. Every dollar spent saves approximately $7 to the community with incarcerations and other costs related to that. And when you include healthcare costs, you get a 12-to-1 savings. You also reduce a lot of conflicts in the families, in work areas. You get better productivity out of workers, and there's fewer drug-related accidents. So what are some models of integration? I came from Minnesota, so I start out with that one. It's a Diamond program, and actually I have some friends that are working in that program. One of the differences there, they have some larger PCP clinics. So a couple psych nurses work in these clinics, and so whenever a PCP sees someone, they do some standardized testing, and if they have depression, anxiety, or some other psychiatric illness, they will have the psychiatric nurse stop in and greet the patient, because that nurse is going to follow up with the patient within a day or two to make sure they got their medications filled, if they have any questions. And then they also do follow-up calls to make sure that everything's going okay, to see if they need to increase the level of intervention, referring them to a psychiatrist or something. What they have found is that they can manage a great many patients in the PCP's office without increasing the level of care, which is cost-effective. They call it iCare, and this is integrated, collaborative, accessible, respectful, and evidence-based. And Governor Perdue's goal was really to establish a national model for integrated approaches to behavioral and primary health services for patients with mental health that are developmental, and also the developmentally disabled and substance abuse problems. He wanted this to be a national project. And it's really integrating the care into the primary care office. Colorado's program is called SHAPE. And the interesting thing about this one, which I think is very important, is they have a payment model that supports it. It includes a global payment, because many of these programs, you need additional providers. Especially as we learned this morning, we're kind of in that crossroads between fee-for-service and this new model of care. And right now, our payment structure is not here. It's still back here in the fee-for-service. So we need to develop some way to pay for these additional resources to help reduce cost overall. Many of you are familiar with SBIRT, the screening, brief intervention, and referral to treatment. Studies have been done looking at how just a brief intervention by the PCP, talking to someone about their substance use, reduces the amount of substance use. Now, of course, those of us that are familiar with addiction treatment, this works for those that have not really crossed over into the full-blown addiction, but more in the abuse stage. But if you look, many substances have significantly reduced with just that brief intervention. Now, this is a special technique. It needs to be taught to PCPs or other persons that will be doing this intervention, but it is highly effective. So in summary, for my part of the presentation, is that behavioral health disorders are very common. We need to integrate behavioral health and primary care to really identify that illness early. We want to save healthcare dollars. We want to reduce the stigma. We want to just have it normalized. We also need to lead to better compliances with other medical disorders if they get treatment for their mental illness. And we also need insurance or payer models to support this integration. We need a residential care for adults for mental illness, and we also need more community supports and treatments. Thank you.
Okay, up next we've got Dr. Michael Christopher. Again, for those of you who came in a little bit late, please hold your questions till all three presenters have done, and then you can address them at the end there. Thank you.
Hello. I'm going to give you a few brief slides and stuff. If you want a great deal of stuff, email me. I will send you this, and it's got like over 100 different tables and graphs documenting all this stuff, 63 pages of mind-numbing data, most of which is depressing, so I'm just going to give you little bits and pieces. However, there is some good news in there. And I want to at least touch on the fact that one of the major things is that we now have good data on the problem. Just to give you a bigger picture, I said I'm a sociologist. I think it's important to get an idea of where the United States fits in terms of mental health. You can see that we have higher rates for most forms of mental illness. A sociologist could give you lots of good reasons for that, but I won't go into it. One of them certainly has to be our healthcare system and the fact that it often intervenes very late. Categories which you're probably all aware of, but worth putting in perspective. I always tell the police officers who I train in mental health that 1 in 4 of the general population at any time has qualifies for a mental health disorder. So if you look around and the 3 people closest to you look okay, you know where the problem is. Okay, so the real story. You know, there was never a time when everybody who had SMI was institutionalized, but there was a time when the percentage of people that were hospitalized was much higher. And some of these hospitals were truly horrible and got the term snake pit. But they weren't all horrible. In fact, many of them were better than where people currently end up, which is mostly in prison, not hospitals. We've got less psychiatric hospitals and inpatient beds every year since the Kennedy administration, despite an increase of 130 million people in population in this country. The promise was community mental health services. And we have some great community mental health services that do a lot of great work. But the fact is they've never been close to adequately funded, not even a fraction of what they should be. And oftentimes, I mean, I've lived through a cut in them and now attempt to restore them up to the 2009 levels. I was here in 2009. It was a terrible funding level in 2009, and we're trying to get back up to that. Let's see. So, okay. In 2002, there were 763,000 people living outside mental institutions who would have been institutionalized by the 1950s criteria. Now, the success part of this is that more and more people are living well in the community. And that is undoubtedly true. The failure is that for the worst of these people, rather than being in hospitals, they're now in jail and on the streets. The inadequacy of inpatient mental health care is really embarrassing. In 2010, there were 13 million people with SMI in the United States. In 2010, there were 100,000 inpatient beds in the United States. Most of the time they're full. It's difficult to get into them. And in Hawaii, realistically, the only way to get into the state hospital is to commit a crime. Even though technically you should be able to get in there for other reasons, the reality is you can't. And it has to, and even people who have been to the state hospital, know they should be in the state hospital, want to go back to the state hospital, often can't get back in. And then there are also people in the state hospital that never should have been there in the first place and taking up beds, and so it's a problem. So the new mental health institution is primarily prisons. There are 320,000 to 670,000 SMI people in prison or jail in the United States. 21 to 24% of the incarcerated population are SMI. 90% meet criteria for some kind of mental illness. The real mental health housing is here, sidewalks and streets. 150 to 200,000 homeless in the US with schizophrenia or bipolar. More people with untreated SMI living on the streets than there are in hospitals. 0.7% of all SMI are in hospitals at any given time, so less than 1%. Now that doesn't mean they all should be in the hospital. The vast majority, my family's full of bipolar, schizophrenia. They all do very well outside, and the vast majority of people with SMI can function in the community, but there's a significant portion that can't. People with SMI are 300 to 700% more likely to be housed in jail than they are in a hospital. They're 150 to 200% more likely to sleep on the street than they are to sleep in a hospital. They're 2.5 times more likely than the general population to engage in violence. But that's when they're in a psychotic episode. When people with SMI aren't psychotic, their violence rate is no lower or no higher than the general population. But when they are psychotic, there is a risk. Incarcerated people with SMI without adequate treatment increase the likelihood there will be violence in the future. I deal with this on a daily basis. I just had a call earlier today, 20 minutes ago, about a psychotic person who didn't quite meet the criteria for MH1, involuntary trip to the hospital. But I will get a call back later today or tomorrow when it escalates to a certain level. It's a familiar person, and I just had to tell them they're not sick enough yet. Tell them to call us back when it gets more threatening. This is a daily occurrence, multiple times every day. 7 to 10% of all police interactions involve interaction with an SMI. That's nationwide. That's about 19 to 27,000 interactions per year in just the Honolulu Police Department. Our program, which is called the Emergency Psychological Services and Jail Diversion Program, so all that, hey, it's changing on its own, responded to 3,000 calls last year, and that's going to continue to go up. In 2007, we were getting about 100 calls a month. 2010, 200 calls a month. 2013, 300 calls a month. Now, there are a couple reasons for that. One is, I think the problem is getting worse, but two, the police officers are better trained. We have more facilities, so they're calling more. I think the number should have been 300 a month back in 2007, but every year I do more training. As I train more, they call more. But the incidents are probably going up as well. This is one of, like I said, hundreds of charts, if you want to look in here, tracking different types of symptoms involved in these calls. But 56% of those 3,000 calls involved SMI, 20% alcohol, 22% illegal drug, 62% involved dangerous to self, and 39% dangerous to others. The reality is they're usually dangerous to themselves, but it is not uncommon for them to be dangerous to others as well. These are different types of interventions. What can we do? Send a CMO out, do an MH1, which is an involuntary trip to the hospital. You can see that the one that's going up is the involuntary trips. The amount of voluntary help, as within CMO, sending someone out to the scene, has stayed pretty level over the last 6 or 7 years. Which hospital do they go to? Well, 70% go to Queens, 30% go to Castle, and a bunch of additional slack. Tripler takes about 1% because they only take people that qualify for services at Tripler. But Queens has been carrying the lion's share of the load for as long as I've been doing this. Frequency. People say, well, how many people are we talking about? And how much help do they get? Well, if you just do it in gross numbers, 85% of the people that we send to the hospital, we don't see again for at least a year. They get sufficient help, they get stabilized, we don't see them. The remaining 15% we see over and over and over. So depending on how you count them, if you do 2,000, or if you do 2 times during a 1-year period, we had 496 people. We had one person that was sent to the hospital 26 times. That's basically once a month for 2 years. And sometimes it's not spread out. Sometimes it's multiple times in a week. And the reality is we're not good at helping this population. We're good at helping the other 85%, but this 15%, we don't do a very good job with. Monthly detainees versus number of mentally ill detainees. Detainees, these are people who've been arrested. We still arrest 2 mentally ill people, seriously mentally ill people, for every 1 we divert to the hospital. But you'll see in 2010, 24% of everyone arrested had SMI or severe substance abuse. By 2011, it was up to 29%. In 2012, it was up to 44%. And this is despite the fact that we've tripled the number of people that we are sending to the hospital, diverting out of jail. So we're diverting more and more people, and yet the numbers aren't getting better. They're getting worse in terms of arrests. Number of detainees homeless versus homeless with SMI. 44% of arrestees were SMI in 2012. 39% of arrestees were homeless, and 58% of all homeless arrestees were also SMI. This is the model, the federal model we're attempting to, they call it the sequential intercept model. The idea is that there will be a mental health component of every part of the criminal justice system. Our program adjusts Intercept 1 with law enforcement, and to some extent Program 2 or Intercept 2 post-arrest. We're getting better and better at this. We now have, at least conceptually, partial agreement for integrating all of these parts, but it's taken 7 years to get this part of it operating fairly smoothly. I don't know how many years it's going to take to get the rest going, but there are programs in each of these, but they don't communicate with each other. They're largely disconnected, and they don't share data. We now share data with Department of Health, the hospitals, our post-booking and pre-booking data, meaning before and after arrest, and a little bit with EMS. Next year's report, I hope to include a lot more data from hospitals and EMS, and to begin our next level of integration, which is connecting data with the court system. When people make it in, they pass out of our cell block into the court system. What's the missing piece? Well, everybody talks about a lot of the other ones. I like to mention this one because it's the one that people don't like to talk about because it's expensive. But the fact is, we need a modern public mental health hospital that provides short-term and long-term inpatient care. This population is never going to be adequately served with improved community mental health services. I'm not saying we don't need that. That'll be great. But even if you had a perfect community mental health system, it would not be adequate. There's a significant portion of people who need access to long-term care. For some of them, it might even be lifetime care where they get out occasionally for short periods of time and go back. But the reality is, these are the people that I try and help every day and try and keep out of the criminal justice system. And while we're doing a better and better job, we're not doing nearly as good a job as we could or we should be. And if you want a copy of the 63-page report, email me there and I'll send it to you in electronic form. Thank you.
There's stairs right there, and I just kept thinking as soon as I stood up I was going to fall.
Oh.
The classic Chevy Chase, right? Yes. I'm dating myself. Can you all hear me okay? I'm a little short, so I'm trying to adjust. So I'm going to focus a little bit more on Medicaid. As mentioned earlier, obviously a large percentage of the severely mentally ill here in Hawaii have Medicaid coverage. If some of you actually went to the earlier session on the changes to Medicaid, I believe it was Medicaid 2.0, you may have already gotten a little bit of a preview, so I'm going to talk a little bit about what some of the changes to the mental health system are. But I made my slides a little bit different, so don't tell me that I copied, because hopefully I didn't. So before that, and I just want to make sure everybody's aware, I don't know if you all have been checking your smartphones, and maybe that's why the room's kind of thinned out a little bit, but there's a little bit of a crisis going on today. Has anyone heard about the Butterball issue? So Butterball, see, some of you read the article already. Butterball apparently is having a shortage of really big turkeys. So when you leave today, go to Safeway and pick up the biggest one you can, because apparently it looks like there's going to be a run on them this week. So I'm Wendy Morriarty. I did spend the early part of my career as a psychiatric nurse actually in a community mental health center that had long-term residential and acute beds. And I'm laughing hearing the different stories because when Medicaid came into our center, that was the good payer. So I view the system as a little bit different, so I can imagine from Queen's perspective where you all sit. That also does back up the validation that if Medicaid was the good payer for the community mental health center, that also validates community mental health centers need more funding. So appreciate all of that. So this is what I'm going to go over. So first and foremost, I never met a brain without a body. I heard this years ago at a mental health conference, and I love it. I've met a few bodies without brains before. But the reverse is not true. And I see a couple physicians in the room, and I can tell you, as a psychiatric nurse, it's amazing what people will tell you. When people ask, what do you do for a living? And I would say, well, now when I say I work for a managed care company, they go, oh. So I get a little different reaction. When you work for a behavioral health psych nurse, it was amazing how people would just tell you things. And I will tell you that this is something that you have no idea. When the stat before came up with 1 in 4, it really is 1 in 4. And 1 in 4, a lot of severe mental illness is out there. People don't talk about it. Real quick, as a woman, one thing women tend not to talk about is having a miscarriage. But I'll tell you, if the topic comes up, you'd be amazed at how many women miscarry babies. The same thing with mental illness. People don't talk about it. But it's amazing. Anybody I would meet when I explained that's what I did, my uncle, my aunt, my parent, my child, it's a lot more prevalent out there. So I apologize, I have to do my soapbox moment on that one, but it's a lot more common. Given I kind of recognize a lot of people in the audience, you all know that, so I'm preaching to the choir. So what is the deal with the integrated care? Why is it so important? So the rates of comorbid medical disorders are astronomical with this population. They tend to have a life expectancy anywhere, depending on the literature, 10 to 20 years shorter than somebody without SMI. I mean, that is just amazing to think about. They tend to have high rates of tobacco use, co-occurring substance abuse. They tend not to engage primary care physicians, or if they do, they don't engage the primary care physician as their primary point of contact. These also tend to be your super utilizers, right? You've gone to some of these presentations, you hear stuff in the news about, the frequent flyers, the ones that are in and out, right? This is gonna be that core population, the hardest population to treat. So this population is probably one of the largest cost drivers for the Medicaid program. So I was doing a presentation a few weeks ago at the state hospital, and somebody had asked the question, it may have been you, Scott, well, why? Why do they die so much earlier, somebody afflicted with mental illness? And one of the things you have to look at that's actually not even captured on this slide, right? You've got rates of comorbid disease. So if you already have something like, say, a diabetes or a congestive heart failure, and you have a mental illness on top of that, adherence is going to be very, very challenging. The other thing, going back to the earlier presentation, you look at a lot of these folks, they are out living on the street. That is a hard life. They could potentially be substance abusing, they could be homeless, they're in and out of the jails. This is not the kind of living that lends itself to living to a ripe old age. So the challenge of integration, because I think we all agree, you're all sitting in this room, I imagine everybody agrees integration is the way to go. So why is it not happening? With the exception of a few FQHCs, and we've got a couple amazing FQHCs here in the state, they are perfectly positioned to integrate the care. But most of our PCP offices are not. We don't have large, robust, big coordinated systems that are able to embed behavioral health providers in them. The other thing which I found most interesting is a lot of PCPs are not comfortable with the whole concept of behavioral health. And I found this across the profession in general. It's interesting because I've worked with behavioral health clinicians who feel more comfortable learning about medical disorders, but for some reason, sometimes the medical professionals, when they hear behavioral health, especially SMI, they just go running for the hills. That's not something they can handle. That's not something they feel like they've got the expertise to do. Limited financial incentives to integrate care. Same thing, if you take your independent physician, your PCP, and they've got a small practice, they're barely making their overhead as it is, and now asking them to kind of have bricks and mortar, bring in maybe a therapist or a psychiatric nurse to have somebody on site, it really just isn't realistic. There's also some challenges around sharing protected information. You would think we're at the point now where we're going to have these magical electronic medical systems that are going to talk to each other and they're in the cloud, but there still is a lot of challenges in sharing information and a lot of challenges specifically that wrap around the privacy rules around behavioral health information. Ooh, I need to go back. So what's the state behavioral health transformation goals? You probably saw these in the earlier presentation if you saw this, but there was a joint meeting with Department of Health and Department of Human Services back in July where we outlined kind of what the goals for the state were. Obviously, you can read, providing more services to more beneficiaries. You heard about some of the expanded services in the earlier presentation. Clinical continuity, this is a huge one. Simplifying the system. I'm going to show a couple of those slides that you may have seen this morning, but the behavioral health system in Hawaii for Medicaid members was probably one of the most complicated and fragmented systems when you look at how it really had been operating over the past couple of years. So it's no wonder that there were consumers falling through the cracks. Providers have a hard time understanding it. So as far as I'm concerned, if you're a provider and you're confused, we were definitely doing something wrong. So I think the state is really moving in a good direction with that. Reducing administrative burdens, improving efficiencies, and optimizing federal match, so trying to draw down more of those federal dollars for some of the behavioral health services that the state had already been providing using all state funds. So this may be what you saw earlier. I changed its color so it looks different so she can't say I cut and pasted. This was prior to 9/1, this was the status. If you were an SMI Medicaid adult, you could get your behavioral health services from all these different ways. Maybe you could get them from your Quest plan, and each Quest plan, by the way, could implement them differently. So sometimes Quest plans would outsource, sometimes they'd use community providers, sometimes they'd have their own providers. So even there was layers of confusion even within that. I see a couple heads shaking. You could get services through your QXA plan. You could get services through the CCS program. You could get services directly through AMHD. Or like I said, or you could get the specialized services through your Quest plan. So today, better, right? We're seeing less boxes there. So now if you're SMI, SPMI, and you're in the QXA bucket, which is your aged, blind, disabled Medicaid, you're going to receive all of your behavioral health services, your specialty services, through the CCS program. So from a provider perspective, we hope it's a lot easier already to even figure out if you've got somebody who's in this bucket, this is where the dollars are coming, this is where the services are coming. But we still have one more step we can go, and that's this. Right? Try to make it as easy and simple as possible. So once this rolls out, and this is planned for 2014, I believe the DHS announced this morning it's going to be happening in April. Anybody who's diagnosed as SMI on Medicaid and qualifies for the specialized behavioral health services will now have all of those services provided through the CCS program. From a provider perspective, we also hope that really decreases confusion out there as to who's responsible for paying for some of these specialty services. This also coincidentally, I'm sure this is not a coincidence, aligns with the Quest integration program, which is combining the Quest and QXA programs, which will go live 1/1/15. So hopefully much less confusion. The CCS program, as you've heard me mention, this is the DHS specific program that provides the specialty behavioral health services to folks that are eligible for Medicaid and have a severe mental illness. Right now, we've got just over 4,000 members, I believe, statewide, and we believe the Quest population that's supposed to be moving in sometime next spring is going to be an additional approximately 1,500. So it looks like grand total when the program is fully complete next year, it's looking about maybe 6,000 maximum. So OhanaHealth plan, we were the plan that was awarded the CCS contract. I think sometimes it gets a little confusing because we're also a medical health plan that combines both. So you'll hear me speak to when we talk about coordinating with medical plans. I can be speaking about coordinating with myself, which is interesting, or coordinating with any of the other Medicaid health plans. So what's our vision? We approached this contract a little bit differently, we think, than the prior vendor. We were really strong on member choice and trying to contract with the folks out in the community. So we really felt that the providers in the community are the ones best equipped to do this service. So we're not doing any of the case management in-house. We're using all of the current providers. Improved quality and improved accountability. One of the keys to accomplishing it, obviously first and foremost, collaboration with the member's health plan. And again, you think this sounds easy, but it can be very challenging. What we found without line of sight in the old system was you didn't know who the case manager was, you didn't know which case management agency it was, and a lot of times the members themselves don't know. You know, they may know the name, you know, Wendy comes out, but they don't know Wendy works for Helping Hands, or they don't know, you know, that's maybe my medical case manager versus my behavioral case manager. So really just getting line of sight to all the data right there will increase the collaboration, improve outcomes. Medication reconciliation and adherence monitoring. In the past, the way the program was administered, the health plan still kept a lot of the data around medication adherence and didn't have line of sight to things like ER utilization and acute care stays. And now all of that's rolled into one program, so that way it can all be tracked as one thing. Keeping the behavioral health providers accountable for sharing. Having the same set of criteria for all the different providers across the state, we think will really make a difference in really trying to determine how do we measure the quality of case management. I mean, that's a hard one. That's not, you know, it's not measuring the outcomes of a diabetic and do you keep their blood sugar under control. How do we really measure the various factors that go into really good positive case management? So, how are we going to integrate this, considering it's a carve-out? Number one, as I mentioned, you have to be able to identify this population, and I think that's been one of the biggest challenges we've seen. And then the behavioral health providers don't have any idea that the member has 4 or 5 different medical specialists, so the two sides really haven't been talking to each other. You got to engage the health plans to facilitate data exchange. Right now, this is easy because it's down to 2 health plans. When we open up to the Quest plans, we're hoping to get a much more robust data exchange between the two. Finally, the last one. Encourage the PCPs to pursue the patient-centered medical home status. I know as a payer, there's a bunch of different things, if you heard in the Medicaid presentation, that we're really trying to encourage different payment methodologies, and Medicaid's also driving this as well to really try to integrate and coordinate the care.
Okay, awesome. Thank you.
Saw this here.
Well, thank you so much, you guys. That was, I think one of the things that was very interesting about the presenters that we saw was that they definitely were speaking about different aspects of the system. So we had folks talking from the justice system perspective and from the Queen's perspective about talking about what happens at sort of the SPMI end of things, as well as talking about what as a large group SPMI folks might be seeing with respect to primary care, integrated care, and those kinds of things. And in each of your presentations, really looking toward what you would see, and I really appreciated that you highlighted 1 or 2 key things that you thought would really do something toward making a difference. I guess one of the things I guess I would wonder about is how, from where I'm listening to this, I guess one of the things I'm thinking about is how do you think the state transformation that's happening now, let's talk timeline about how realistic it is that the things you're talking about or the fixes that you see as impending, how soon could we expect that any of those things would happen? Just sort of grounding it in kind of time. Do you see these things as things our next generation's going to do? Do you see these things as things we're going to get to now? Because it's a we thing. In this room in particular, this is we. Everybody else went to the talks about other stuff. So this is the behavioral health crew right here. So what do you guys see?
I think we're partially on the way now. As I mentioned, you know, some of the FQHCs are pretty far along, some of the larger practices are, but I don't think we're ever going to get to a point where 100% it's realistic that you're going to have fully integrated care. Going back to the example, we have rural docs. You know, if you look at the neighbor islands, for example, there aren't the resources there to do it. So I think we're always going to kind of have a hybrid type model, but I definitely think, you know, I'm encouraged by all of the attention to mental health. I mean, for a while, mental health was completely ignored in conversations and even conferences like this. Mm-hmm. You know, they had the special mental health conferences that you went to, right? You know, you weren't a real nurse if you were a psychiatric nurse. And I feel like that's changed, and I think that's positive.
Yeah, mine's entirely anecdotal or experiential, but I've been doing this 7 years, and I have to say, in terms of the dialogue, in terms of actual concrete planning for the future, it's better than it's ever been. I mean, for the first time, I feel like there actually is some discussion of the long term. I used to almost get drummed out of room for mentioning a state hospital. When I started, now I see people shake their heads and they say, yeah, that's true. And so I think that's changing. And in my area, I've seen the Department of Health redirect some resources toward the front door, which I think took years to get people to realize we got to pay attention to this area. But realistically, these are all long-term problems. My wife told me you can't do anything worthwhile in life in less than 10 years. And I've really come to believe that she's right. So I don't know when we started that. I mean, I like to think it started 7 years ago and we got 3 to go. But
when we talk about the super utilizer, boy, that's a loaded one right there. When we talk about the populations that I spend most of my time working with, I would guess that they fall in the category of super user. So what are the, I really appreciated your reference to the social determinants of what causes or what contributes to matriculation into services and impairment of their ability to avoid ER hospitalization. I really appreciated all of those things. So I guess from my perspective, thinking about what is it that we would need to do beyond sort of broad stroke systemic things, but related to what is that hybrid? What would that look like to reach those populations most in need, and really how would we do things different in that domain? And yet, I suspect there are other folks out there that were going to ask that question. So I'm going to invite you folks up to the mic now to ask questions. We can just, one at a time works. Great, please.
Howdy. I'd like to ask each of you to answer this. HHS has told me that the greatest disparity in American healthcare is that the mentally ill die 25 years younger. I won't argue with it. But I've also been told that Medicaid is the largest single line item on the Hawaii state budget, and that 14% of that population have multiple chronic conditions and use 90% of those Medicaid dollars, and that 2/3 of that 14% behavioral health is one of those chronic conditions. And if you figure that out, I want to know how come this isn't the single most important problem to the state of Hawaii.
That sounds like a great question for the big square building and the folks there that do some of these policy and legislative decisions. It's probably not that dramatic, Scott. I mean, I'll put on my health plan hat right now. As far as, is this population causing the vast majority of CAID spend dollars? Probably a lot of it. I don't think it's 90%. From what we see, but I will tell you that when we look at even our high medical spend utilizers, and we track all that as a health plan, and you start to peel back the layers, it absolutely, I would say probably 70% of the time, you get down to a certain layer and there was a comorbid behavioral health condition or some other type of social factor that was impacting that. So I think the plans are looking at it, and I know for a fact the state is looking at it.
And I suspect if you add cultural diversity into there, if you saw that with Native Hawaiian Pacific Islanders, that would be another significant chunk of that.
Another layer.
Yep.
Well, I'll give you my rather cynical answer, and it's that the people with SMI don't have lobbyists. And that's, the reality is that they don't have the influence in the political system. It should be, if not the number one of the number one focus, but it isn't. It's way, way, way at the bottom because they don't have lobbyists.
I agree with that, but I do see increase in interest in some of the legislators, which I think is very positive. But we need to continue that excitement and make it broader with the legislature.
Thank you. Please.
Okay, I'm Steve Kemble. I'm a psychiatrist who also trained as an internist, and I've been working as a psychiatrist in the General Medical Clinic at Queens for 24 years now, so I'm living integration.
Yay.
And I agree with everything that Karen and Michael said, and my comments are really for Wendy, who is supposed to be trying to do something about it, and I have some comments and suggestions on that.
And if I can, just before, if you can pick
Yeah.
your favorite one, please, that would be really helpful.
Well, managed care was founded on the idea that there's too much care being delivered, and it relies on mechanisms to try to deter and obstruct care. And this has been worse for psychiatry. I think that psychiatrists have largely left treating Medicaid because of the hassle factor, not just the pay, but the hassle factor. And we really need a system that supports them to deliver care for difficult patients rather than obstructs them. And I'm working in Queen Emma Clinic, and 40% of my patient encounters involve some kind of obstruction to care. The most common is a formulary restriction that I have to jump through hoops to resolve. There's also patients who get bumped from their insurance because they fail to turn in paperwork on time, or who get dropped from care when they switch plans because they switch categories, which will be better with Quest integration. So there's 40% of the encounters involve a system problem that obstructs my ability to just give them the care that they need, and that's really unconscionable. I also think that the idea of a carve-out is a mistake because I was involved with a behavioral health carve-out early in the Medicaid program, and it obstructs the integration of care because who's going to pay for it, the behavioral health contractor or the main plan? It would be better if we paid for the services needed for the seriously mentally ill as a separate program, but left the pot of money for the care delivery and all in one pot so we can keep it integrated.
Okay, thank you.
A long time ago, President Kennedy asked Wernher von Braun, what do we need to get to the moon? And Wernher von Braun said, the will to do it. And that's the essential thing that's lacking in all of this. We can say they need this, they need that, they need everything else, but the fact is our society does not want to pay for this, so they're not going to get it. So I think it's somewhat disingenuous to believe that you're going to have integration with primary care, because currently Hawaii has an aging physician population. They're working 50 to 60 hours currently. That's for the acute care that's given. We're having an aging population of more and more chronic care to be given. So if you were going to treat all of the current patients you need, plus all the chronic care that you need, you're going to need at least another 8 or 10 hours a day to get that done. So nobody, especially if there's no money involved, is going to be taking care of all these difficult, complex, annoying to deal with paperwork, mentally ill people. So I think what's lacking is, the total will to do any of this.
I'll just make just one quick comment on that. I agree that you do need the will to do it. It's not that it's a single provider doing everything, but it's the group of resources that need to come together to help integrate care. So I do agree. We do have an aging workforce. We have a lack of PCPs. We have a lot of work ahead of us. But integrating care would help everyone.
And will to do it starts with everybody in this room.
Yep.
And I wish I only worked 50, 60 hours a week. I work 70 hours a week. But I do honestly think just the last couple of years there has been some progress. It seems like we're moving in a better direction, but whether it's going to take 10 years, 20 years, or never is, I can't answer.
In the last 10 years, has the amount of homeless people in Hawaii gone up or down?
No, it's getting worse.
It's getting worse. So you're saying we're turning the corner, and when I go out on Alamoana Boulevard, it's not getting any better.
Yeah, it's. I have to be somewhat optimistic, or I wouldn't be able to get up in the morning.
Yes.
Yes.
Please.
Yeah, hi, my name is Lisa Mitchell. I'm here, I'm a massage therapist, and I'm surprised. I feel like the huge missing component is alternative care, not care, but alternative, holistic approaches, definitely more spiritual approach to the whole thing. If you look at the system, if you look at life from a broader vantage point, rather than looking at all the little pieces, the vision I feel like for this whole summit ought to be wellness, not, sickness and how to get well. That we are well. We are well, and how do we get to this sick place, really, should be the bigger question. And I think a lot of the problem is we're not asking that. So there was an article, the headlines yesterday, state rep with a sledgehammer. What does that say about what's going on in our society? I mean, we have pictures all over the place of all the problems, and we just keep compounding that. We're not looking to the solution. And I think the solution is such an easy one. It's so apparent. I've been studying Carolyn Mace, energetic anatomy stuff over 10 years ago. I'm studying other things right now that talks about healing, and healing is all about emotional. Everything physical stems from our emotions. And that's why, yes, this group here is very important. It's important to recognize, and I think you all do recognize that, yes, it is from our social distresses that our physical is so large as well. But yeah, and that all of us have these social difficulties, let's say. And we have to ask ourselves why. What is going on in society that keeps us at this place and getting worse?
Okay.
And indeed,
Mahalo. Yeah, mahalo. Does anybody want to?
I was going to say, and I actually looked to the good doctor next to me because he'll probably know the answer, but years ago I had heard that one of the lowest rates of schizophrenia as far as being a detrimental diagnosis was in Africa, and it was a tribal Africa. And the rationale behind it, supposedly, because it was accepted and embraced as opposed to stigmatized. Mm-hmm. And I think that goes to the whole concept of health and wellness. And a lot of the outcomes, I think, are poor because we don't look at those other factors. Mm-hmm.
Well,
Not very?
The rate for schizophrenia is about 1% in every population around the world, regardless of culture. How you respond to it is very different. I was a very spiritual person. I vote, I read, I study science. These are all spiritual acts. If you're caring about someone else, spirituality is in the details. It's not in the vague sense. It's in the details, the hard stuff. It's in the dollars, it's in the laws. That's where spirituality is. If you're not involved in the details, you're making yourself feel better. You're not making other people better.
Yes, aloha. I want to underline my support for the integrated model. However, I think that we have hijacked the term, the health delivery system, by just a Western medical system. And when we talk about integration, on one hand, we talk about mental health, alcohol and drugs, and primary health care. And yet we forget all of these other models of thought field therapy, of massage, of acupuncture, and the rest. And I think to make the paradigm shift, what we really need to do is understand that the health care system is far more than merely the medical delivery system. And that is one major area that we need to make the shift. The second point I'd like to make is that when we deal with the integration of primary health care with mental health care, I can understand that it would be appropriate to place it within a primary health environment. But when you're dealing with serious mental illness, or serious and persistent mental illness, the approach that one takes to addressing the needs of a client is quite different from what you will find within a medical center. The case manager really is a primary person. Of course, you need a psychiatrist, but the key there is a case management of that recovery plan, or a family recovery plan.
Mahalo, Pokai. I think at this point we're actually past the time that the panel was supposed to go on, so I think this is the time that we're supposed to allow for transition. So for those of you that are going to transition on, please feel free to do so. I do want to honor that you were still standing in line at that time, so if you want to go ahead and ask your last question, please do.
I have an actual question. I'm Diane Brookins. And the integration thing is wonderful, but we've got this tension between sharing information as needed for integration and special protections afforded to behavioral health information. What are we doing about it?
As been one of the recurring themes, I think that was to the point about having more legislative and policy activity and having more lobbyists to speak to these kind of things, because this one definitely would take some type of Hawaii administrative rule change.
Yeah. Okay, thank you everybody for participating. It's awesome. Thank you so much.